go on to our last speaker, Dr. Vijayalakshmi, who's a medical consultant, glaucoma services at Arvind Eye Care Systems, Madurai. And she is going to tell us something very important, optimizing management of lens-induced glaucoma. Sorry that you had to be patient till the end, but I'm sure, like us, you enjoyed all the talks this far.
Yes, ma'am. Thank you, ma'am. So today I'll be discussing on optimizing management of lens-induced glaucoma. A brief introduction. Lens-induced glaucomas are the commonest cause of secondary glaucomas. It is common in developing countries with an incidence of 2.4%. And it is seen in elderly patients, especially in females. Most of these lens-induced glaucomas, especially phacolytic and phacomorphic, they present as ophthalmic emergencies. That is, they need immediate surgical intervention within 48 to 72 hours of presentation. This is because acute rise in intraocular pressure can lead to compromised function of the optic nerve. As we all know, cataract surgery is the treatment of choice in all these patients. So to achieve optimum visual outcome, there has to be certain preoperative, intraoperative, and postoperative care, which I will be discussing in subsequent slides. First is preoperative clinical assessment. Proper documentation of perception of light and projection of rays is very important before taking up the patient for surgery. So few patients may not cooperate for perception of light, and in some patients, PR can be inaccurate. Still, inaccurate PR is not an absolute contraindication in proceeding with cataract extraction. And proper documentation of slit lamp biomicroscopic findings like corneal edema, presence of any bullae, and density of cataract, whether it is a intumescent cataract or a hypermature cataract, any subluxation or any phacodonosis, everything needs to be documented in the slit lamp examination. And IOP recording by applanation tonometry is also mandatory. If a patient is going to be a phacomorphic glaucoma, documentation of gonioscopic finding in the fellow eye is essential, because few patients can have occludable angle in the fellow eye, which needs prophylactic laser treatment in the fellow eye. In patients with inaccurate PR or patients who are not cooperating for perception of light, then we need to plan a B-scan ultrasonography for proper documentation of posterior segment findings, and accurate biometry is also mandatory. A proper documentation of a signed guarded visual consent form is very essential. Anticipating all the intraop complications, even the risk of expulsive hemorrhage, need for resurgery, and prolonged visual recovery, everything needs to be documented well before taking up the patient for surgery. Now coming to preoperative management part, reduction of intraocular pressure as well as control of inflammation is very essential. So intraocular pressure reduction can be achieved by using ABC, that is alpha agonists, beta blockers, and carbonic anhydrase inhibitors, both topical and systemic. In few patients who are really symptomatic or in whom the intraocular pressure is very high, in the range of 60 to 70, then we may have to plan a dose of IV mannitol or oral glycerol. The drugs which are contraindicated in these patients are PG analogs and pilocarpine. And inflammatory control can be achieved by topical steroids, and cycloplegics is needed in patients with phacolytic glaucoma and lens particle glaucoma. So regarding intraoperative challenges, so since we are going to deal with the globe with a very high intraocular pressure, there is an anticipated chance of expulsive hemorrhage, and also achieving a proper rhexis is going to be technically challenging due to poor visibility as a result of corneal edema and absent red glow due to mature or hypermature cataract. And these patients can have coexisting inflammation and pseudoexfoliation, which can lead to poorly dilating pupil, and also chronic zonal laxity can lead to difficulty in rhexis. So I'll be showing you a few videos of how cataract surgery is done in a patient with phacomorphic glaucoma. This is a 64-year-old patient who has been diagnosed with phacomorphic glaucoma with an intraocular pressure of 48, and he had been treated with topical and systemic anti-glaucoma eye drops and steroids. And under IV mannitol and subtenon anesthesia, the patient is taken up for cataract surgery. So, after conjugal peritomy and cautery, a 6 to 7 mm of sclerocorneal tunnel is made, and then adequate care has to be taken to create adequate side pockets, because these patients are going to have a intumescent brown cataract. Next comes the most important step, that is controlled paracentesis. Since these patients can have shallow anterior chamber as well as peripheral flat AC, risk of iris prolapse as well as touching the ALC is going to be high. And then the ALC is stained with tryptophan blue dye. Tunnel entry is made with bevel down keratome. And next comes the most important step, that is decreasing the intralenticular pressure by making a small nick in the ALC and letting the intralenticular fluid to come out of the bag. So this gives us some space to operate in the anterior chamber. Once the adequate rhexis is achieved, nucleus can be gently wheeled out of the bag using bimanual technique, either spatula in one hand or Sinski in one hand, or a viscocannula in one hand or Sinski in the other hand. Then the nucleus is delivered out by means of irrigating vectis method. A gentle cortex wash is done and 3-piece IOL is placed in bag. So this is a patient with a phacolytic glaucoma whose pressure are in the range of 60s and who had been treated with topical and systemic anti-glaucoma medications as well as steroids and cycloplegics. And this patient is also taken up for surgery under IV mannitol. Here you could see there is a poor visualization of ALC due to corneal edema and lens particle in anterior chamber. A gentle paracentesis is made and lens particle in the AC is cleared using a saline cannula. AC is formed with viscoelastic. As you could very well appreciate, the pupil is very small. So the pupillar dilatation can be achieved by using a double Coughlin's hooks or a multiple sphincterotomy or iris hooks. Once adequate pupillar dilatation is achieved, a controlled ALC entry is made with bevel keratome. So this avoid the rhexis extending to the periphery. The anterior chamber is formed with viscoelastic and the rhexis is continued with rhexis forceps. So here you could see the liquefied cortex is hampering the view of the rhexis margin. So it can be cleared by using a viscoelastic. And the rhexis part can be continued. So once the rhexis is completed, nucleus is going to be really small in these patients. So nucleus is gently wheeled out of the bag using bimanual technique. And nucleus is delivered by irrigating vectis method. So care has to be taken that we avoid sudden decompression of the globe. This may lead to whole bag removal.
1 minute remaining.
A gentle cortex wash is done. And 3-piece intraocular lens is placed in bag. And here the most important step is we need to take care of clearing the angles also using the Simca cannula after placing the lens, because to clear the lens particles and inflammatory materials in the angle structures. So we can do a aspiration of the liquefied cortex using the 26 gauge cannula also. So here the pupil dilatation is achieved by using a Vanna scissors. So once this is done, a 26 gauge cannula is introduced, a small ALC nick is made, and liquefied cortex is aspirated using a 26 gauge cannula, and then the anterior chamber can be formed with viscoelastic and the surgical steps continued as described earlier. So this is a challenging case. Here you could see the phacolytic glaucoma. The patient is having a calcified ALC with a poor visualization also due to corneal edema as well as the lens particles in the ALC. So the lens particle is cleared from the anterior chamber. So whenever the surgeon is trying to attempt the rhexis, here you could see the zonal laxity. So the calcified ALC is cut with Vannas and then the surgical step is continued. Now coming to the postoperative care, these patients may need intensive topical steroid, cycloplegics, and topical and systemic glaucoma medications may be needed in immediate postoperative period. And a short course of oral antibiotics may also be needed if the patient is ending up with whole bag removal or PCR. And short course of oral steroids may also be needed in patients with persistent inflammation. And regarding the choice of phaco or SACS, in our setup, we prefer doing SACS because it is much safer than phaco because it causes less stress on the zonals. Whereas in phaco, there could be poor visibility due to corneal edema and also shallow anterior chambers with hard nucleus. It can lead to increased risk of endothelial damage. So choosing the option between SACS or phaco, whatever is safe in surgeon's hand, they can prefer the surgical choice. And next, the doubt is whether to plan for cataract extraction alone or a combined surgery in patients with phacomorphic glaucoma who is presenting a little bit late. So Senthil et al. In this study, they have revealed that both the group, they have shown a similar IOP control, but still the cataract extraction group, they had a faster and better visual recovery. And in patients with painful blind eye, diode CPC can be considered. And thank you for this opportunity. Thank you, ma'am.
Thank you very much. So I'm going to just take one question, and Murli could also ask. Dr. Krishna Das, you're there.
Yeah.
Now, would you, what is the significance of a patient not having a perception of light? Would you still go ahead and do surgery in these patients?
Sometimes, it's very difficult for patients to appreciate even light perception, given the density of cataracts, corneal edema, and high intraocular pressure, pain, etc. So, going by slit lamp features, if there is no evidence of chronic corneal edema, especially in phacomorphic glaucoma, like corneal neovascularization, persistent chronic corneal edema, iris neovascularization, suggesting very long-standing glaucoma. And if you just have a streamy cornea, and the features suggest history, both clinical features suggest that the onset of glaucoma has been recent, even if the patient is not able to perceive or project the lights accurately, we can go ahead. I think even the literature says, especially in phacolytic glaucoma, in very many cases of phacolytic glaucoma with very high intraocular pressure, sometimes the patient may not be able to project or perceive light. I think it is better. It makes sense to go ahead with surgery.
Murli, can you take the next question?
Yeah, I have a question for Dr. Swati. Dr. Swati, do you do most of these GATs in the topical anesthesia, and what would you do if the patient suddenly becomes uncooperative, especially with head positioning or with looking to the opposite side? What would you do? Have you done it under block?
Yeah. I do it under subtenons only, because once I tried doing in topical, it was a bang case, bent ab interno needle goniectomy. I thought it will be small procedure only, I can get away with topical. But then I had a real problem, because once you turn the patient's head on the nasal side and you tilt the microscope, but still the eye can move. So the patient was turning the eye towards the temporal side. So it was very difficult to maintain positioning. So I prefer doing it in subtenons.
Do you use a pineal traction switcher or
No.
thing to position here?
No.
Have you tried this GAT in neovascular glaucomas?
No. Normally, also it bleeds so much that in neovascular glaucoma, I won't dare to.
Dr. Shushmita, what is the percentage of patients in lens-induced glaucoma who actually need glaucoma surgery later?
So I think that depends upon the duration, but I would be comfortable with first taking out the lens and taking a call, because I can't see the disc. I don't know what it's like. But and I think combining a trabeculectomy always is more morbid with cataract surgery. So in any case, I would tell the patient, look, you're most likely going to land up with a glaucoma surgery, but let me take out this cataract first and then see. I would always do sequential.
Yes. Dr. Harshul, would you think of doing a limited vitrectomy in these very highly pressurized eyes besides the medical management? Have you ever needed to do that?
Yeah, I think that a very good point. I was just trying to say that. I don't know how you did telepathy over there, because one has to, if things are very, and you have vitrectomy surgeons with you, you can go ahead and do a small core vitrectomy to debulk the whole thing, because then otherwise, if you suddenly open it up, then you can have chances of problems.
Yes. Anything else, Dr. George? Anybody? You have anything to add? Because this is we've not covered many panel questions in this talk because of I dragged the discussion for far too long in the beginning. Anything very important for the audience you would like to ask the panel?
No, I just want to reiterate what Shushmita had said, what Krishna said, that even if PR is inaccurate, you will go ahead and do a surgery. And a lot of people keep asking, should we do a combined? So Shushmita clarified it very clearly. First, go ahead and do a lens, because lens is the cause in these cases. And then tell the patient that, yes, we may require it. especially if after giving mannitol, still the pressures are very high, then you go ahead and do a cord vitrectomy if it is available to you. Otherwise, you can put in a needle also.
Very nice. Anything else? Any other question to ask?
So one question for Dr. Suhasini. Regarding the glaucoma drainage devices, sometimes you have a conjunctival erosion over the patch graft. So how do we manage that?
Hasini, I think she's not there.
George, can you answer
George
that?
can answer this.
Murli, what is the time at which this erosion has occurred?
So sorry, sir.
No, I want to know whether this erosion is immediate post-op or late post-op. Conjunctival erosion over the patch graft.
In the first 2 weeks of surgery.
Usually, epithelialization will occur, Murli, over that area if it's a small erosion, and it stays there. So I don't think we need to do anything if it is right above the patch graft.
Yes. I think everybody has to go back for their dinner. So I think we will come back with a different interesting session on glaucoma maybe in August, and make it fewer topics and a lot more discussions. I think a lot more will be gained in that. And thank you very much for the amazing contribution of the expert panel and so knowledgeable and informed speakers. Like I felt all of you speakers could have been the expert panel, and that is the level of confidence you all showed in the way you showed your amazing videos. It was truly a great webinar, and I feel I learned a lot in this. And of course, I need to thank my co-moderator. You all have just no idea what an amazing support and energy he has always been through all my webinars. May apparently look quiet, but that gray matter of his really has too many convolutions in it. And again, I think I need to thank AIOS admin, Mr. Kripal, and his team for always being so supportive in our webinars. Sai and Manjula for Numerotech. You can see you must be tired of getting my mails, but please do remember me for the next term when I would stand for the same post. Don't give up on me at all. I'll try to come in a newer, innovative way of having an academic reach for you all. This is not meant for canvassing. This was just a light way, and I said that.
Dr.
And,
Chitra,
yes?
We are planning to have you as a permanent AIOS chair.
My husband might divorce me.
Only if you promise to send dinner by Zomato in these kind of meetings.
I know, very true. And of course, I think I definitely need to thank our sponsors, Entoad, who have been really, really wonderful and constantly there to sponsor every single program of ours. I need to truly thank my ARC team, although they have not been here, but they're always there in the background, supporting and encouraging me forward. And thank you to all our dear attendees. We've had a good number of attendance, and would you believe it, the number keeps increasing with time. And on Sunday, please don't miss my email. Don't overlook it. It has one beautiful ARC video coming with it, which will actually tell you that the future is the webinars, the kind of attendance which has come across, and I have put across our ARC activities very nicely. I look forward to comments from at least this panel after you see that video on Sunday. And thank you so much, one and all of you. Look forward to meeting you all again and again on this platform.